Hi, thanks for joining me. Today we're going to talk about hyperaldosteronism, a condition where the adrenal glands produce excessive aldosterone, leading to a high blood pressure and a mysteriously low potassium levels. Now, before we start blaming it on aldosterone, it is fair to learn about why this occurs, how to spot it, and how to even manage it appropriately. So let's get started. Kindly hit the subscribe button. All right, so I want us to briefly discuss the adrenal cortex, which is a vital component of the endocrine system, and in fact is responsible for the synthesis of essential hormones, right? Very important hormones. So the adrenal gland you can see right there on top of the kidneys, and the adrenal cortex consists of a capsule and three distinct zones. Zona glomerulosa, right there, which is central to our discussion today on hyperaldosteronism. Okay? The zona fasciculator is also the zone that produces cortisol, and zona reticularis subsequently makes adrenal androgens. Let me show you a way to memorize this easily. So you can just write GFR, that is glomerular filtration rate, and map this to, say, acute coronary syndrome. And then you can say that zona glomerulosa produces aldosterone, zona fasciculator makes cortisol, and zona reticularis makes the sex hormones, in this case, the adrenal androgens. So we can say, obviously, it's important to understand that tumors and hyperplasia, which is originating from here, zona glomerulosa, there is a tumor or a hyperplasia, this can actually lead to excessive aldosterone production, resulting in disruptions of fluid balance. By that I mean the control of sodium and water retention. If there is excessive aldosterone production, okay, this would lead to excessive sodium water retention. There will be more reabsorption of sodium and water. And this in turn would lead to more excretion of potassiums, leading to low potassium levels. And in fact, the fluid state would also lead to a higher blood pressure. Okay, so there are times also when the zona fasciculator right here can also be a source for aldosterone, which I'll discuss in another video, a condition we call glucocorticoid remediable aldosteronism. All right, so here we're going to try to highlight the difference between primary and secondary hyperaldosteronism that can be confusing for students sometimes. So, in primary hyperaldosteronism, which is also referred to as Cohen's syndrome, uh, the root cause of the excessive production of aldosterone originates within the adrenal glands, somewhere there. This is an important factor to note. Okay, in primary, the root cause is within the adrenal gland. So, for example, a benign tumor or adenoma or a bilateral hyperplasia of the zona glomerulosa can actually lead to sodium water retention, an increased sodium water reabsorption. That would lead to an increased volume state. In other words, there is actually an increased renal blood flow. Now, the increase in volume and renal blood flow also obviously means that you are increasing the stroke volume and you are increasing the cardiac output, and so you increase the blood pressure, which is not uncommon to see. That is, I mean, hypertension is a clinical manifestation of primary hyperaldosteronism. So, the increased renal blood flow would lead to an increase in sodium delivery to the macula densa. Eventually, that is going to lead to a reduction in the secretion of renin. You need to take note of this. Renin is decreased in primary hyperaldosteronism. Now, the idea obviously is to help reduce the excessive aldosterone that is being made in the adrenal glands. Now, remember that when sodiums are being reabsorbed by the help of aldosterone, okay, sodium and water is being reabsorbed vividly. This is being exchanged for the excretion of potassiums. So as sodiums are vividly being reabsorbed, you are also losing the potassiums. And so people with primary hyperaldosteronism would have a low potassium state, in other words, hypokalemia. Okay, there is also another disease or a genetic impairment called glucocorticoid remediable aldosteronism, where there is also stimulation of aldosterone production, this time from the zona fasciculata and not the zona glomerulosa. All right, so the take home point is that there is a problem within the adrenal glands that can be an adenoma or a bilateral hyperplasia. It leads to sodium water retention, right? That the sodium water reabsorption increases. This will increase the volume state. That is also an increase in the renal blood flow. More volume means there is more stroke volume. More stroke volume means there is more cardiac output. So you would certainly have a higher blood pressure, right? Renin, importantly, is decreased. Okay, renin is decreased. And think about potassiums, which is also being excreted. So there's going to be a hypokalemic state. Now, conversely, secondary hyperaldosteronism involves an external stimulus that leads to a decreased renal blood flow. So the problem is not within the adrenal gland as we saw in primary, but the problem is at the level of this point right here. We can think of volume, we can think of the blood pressure. So, take for an example, severe dehydration. When you are severely dehydrated, you have a decreased volume. Doesn't necessarily mean that the fluid in circulation is low. It is low, but volume is decreased. Think about renal artery stenosis. In this disorder, there is less blood flow through the kidneys. So, renal perfusion will be decreased. All right. Think about congestive cardiac failure. In this case, there is a fluid overload, but we don't mean the fluid overload state, rather, but we are talking about the fluid in circulation. In cardiac failures, there is a low circulating fluid. The heart is not able to pump, that is, cardiac output is decreased. So circulating fluid is low. We don't mean the general fluid, which is off, which is in excess, but we mean the circulating fluid. Just as cirrhosis. Okay, all these can impact volume and blood pressure. When that occurs, there is going to be a delivery that is a less sodium delivery to the macular densa again. And in this case, renin is going to be increased in contrast to what we saw in primary hyperaldosteronism. Renin would increase to compensate in a way that is to help stimulate aldosterone production. All right, and that would obviously lead to sodium water retention, more sodium water reabsorption. That will also try to balance the fluid by increasing sodium and water reabsorption. Right, so this is a key important factor to remember is that renin here is decreased, sorry, is increased, and renin in primary hyperaldosteronism is decreased. All right, this slide here beautifully illustrates the complex hormonal interactions in primary hyperaldosteronism. So we have excessive aldosterone in primary hyperaldosteronism, which binds to mineralocorticoid receptors in the cytosol. The effect is going to be excessive reabsorption of sodiums through the epithelial sodium channels. So the more sodiums that are being reabsorbed would leave a negative trace. Okay, that negative trace in the lumen can be used, that is a gradient used to excrete potassiums into the lumen. So the more sodiums you are reabsorbing, the more potassiums you are excreting. So you lose the potassiums into the urine. So there's going to be a low potassium state. Okay, now the resulting potassium loss will prompt hydrogen ions to also shift into the cells. So hydrogen will now shift into the cells because of the loss of the potassiums. Obviously, this will lead to an increased generation of bicarbonate, and this would lead to a metabolic alkalosis. Another important thing to say is that the hypokalemic state can induce something we call autophagic degradation of aquaporin 2 receptors. So you see these receptors here or channels that are specialized in water reabsorption, and it is under the control of arginine vasopressin. So the low potassium state that we have in primary hyperaldosteronism, the potassiums that are being lost, are actually going to lead to arginine vasopressin resistance, previously known as nephrogenic diabetes insipidus. So it is sometimes uncommon to see diabetes insipidus, specifically arginine vasopressin resistance, in primary hyperaldosteronism. Diagnostics. So, in a patient in whom a high aldosterone state is suspected, you would like to assess the plasma aldosterone concentration, which is expected to be more than 15 nanogram per deciliter. Renin levels is expected to be low in primary hyperaldosteronism. The initial diagnosis of primary hyperaldosteronism is made by measuring the morning aldosterone plasma renin ratio right here. Okay, and so if you take the plasma aldosterone concentration, which is high, and you divide it by renin levels, which is decreased in primary, this is certainly going to be greater than 20 is to 1. Now, in the case of a secondary hyperaldosteronism, you might have a plasma aldosterone concentration elevated, but renin levels are also increased, and so this ratio would not be expected to be the same as that of a primary hyperaldosteronism. Confirmatory tests can involve a provocative test. Okay, you're giving the patient a normal saline, which is like salt. You're giving the patient fludrocortisone or salt tablets. Now, when you give these substances to a normal person, you would expect the plasma aldosterone concentration to decrease. But in primary hyperaldosteronism, the level will still persist. Okay, that's a key factor to remember. Now, once this is confirmed, a CT scan is recommended as the first imaging modality, which is then going to be followed by adrenal venous sampling. This is to precisely locate the source of the excess aldosterone. Usually, aldosterone and cortisol levels are measured in the adrenal venous effluent and peripheral blood, both prior and during administration of ACTH. Okay, so normally the levels should be similar on both sides. If you have an elevated level on one side, it could tell you that that is the source of the excessive aldosterone production. So, the management of primary hyperaldosteronism involves a laparoscopic resection of the adrenal adenoma. Okay. And for patients who are not candidates for surgery or have a bilateral adrenal hyperplasia, medical therapy with mineralocorticoid antagonists like spironolactone, amiloride, or eplerenone may also be advised. In the case of adrenal carcinoma, which has a poor prognosis, surgery with or without mitotain, or in general, may involve a combination of a chemotherapy and radiation therapy as well. In cases of secondary hyperaldosteronism, the optimal approach focuses on addressing the underlying cause of the reduced renal perfusion, such as improving renal blood flow or managing heart failure to control aldosterone levels to mitigate the associated risk. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.